Oh, is Gail? Oh, I'm sorry. Gail Wyatt is our next speaker. Forgive me. I overlooked her because she is online, and I think she's ready to be queued up. And Gail is director of the UCLA Sexual Health Program, and she's on Zoom, and she'll be up in just a moment. Maria, just hold on. You're next.
Can you hear me?
We have your slides, Gail, and we can hear you. Thank you.
Okay. Can you see me, or you're just going to look at the slides?
We also see you. Thank you.
Okay. Okay. I want to thank the committee for inviting me to speak this morning. We have a lot of information to share, and some very interesting questions were sent sort of at the last end of the day on Friday. They are equally as compelling. So I'm hoping to get through what we're offering, what the research has shown, what our programs offer, and then to answer your questions as well in 12 minutes, right? Okay, so the first program that I'd like to describe, and I guess I'm advancing my own slide, is the sexual health program, and it's called Sex and Cookies. This is a program that really helps two different levels of students at UCLA. One are medical professionals or aspiring medical professionals in medical school, public health, graduates, psychology students who actually are taught by our team to teach the first and second year undergraduates at UCLA, males and females. Sex and Cookies came about over 10 years ago because as one of the co-directors of the AIDS Institute, we were looking for something that we could offer students on campus that was fun and pretty fast, and one where they could be very relaxed about the whole format and the fact that they may have a lot of questions. So we offered this program in the dorms. They are in the lounges, so the students come to Sex and Cookies in their pajamas, literally, and they bring computers sometimes they don't. But the important thing is we offer them cookies, and they sit around, and we offer them this information that is really quite comprehensive in one session. And it offers them an opportunity to talk to young people who are just a couple of years older than they, but who have a lot of knowledge about sexual and reproductive health. We want to make sure that students enter UCLA knowing where they can receive more help if needed, and that they know how to protect themselves when they get onto campus, regardless of sexual orientation, lifestyle, or a number of other factors. So these are just examples of some of the information that the students have asked about. We've interviewed, and they do evaluate our program, over 100, close to 150 students have participated. They want facts. They want to know more about the anatomy. They want to see body parts, so we have anatomical charts available for them so that if they're not sure about the terminology, that they can understand, and we can understand each other's language. They want to know specifics about birth control devices, how they work, and are there any other options, perhaps others that they know. They want to see what STIs look like on the skin. And this is challenging because a lot of the illustrations are only with pink skin. We believe in diversity, and some of the illustrations are more difficult for them to see on brown skin or on different tones of skin. And it's important to identify that some of the symptoms and the signs are not the same for each group because of skin color. Sometimes there's no redness. There's only little bumps and lumps that a person has to feel. So touching the body and checking on STI symptoms is an education within itself. We teach the students about access on campus, what it means to consent, because this is a huge issue that not only goes along with the Me Too movement, but it goes on something that's very important on this campus, and that is that everyone understands their right to not consent to some kind of behavior that they're not familiar with, they don't want to participate in, or they don't really understand what the consequences may be. And so we like to make sure that everyone understands what consent means. Of course, termination of pregnancy and abortion and all of that information is also available. Then techniques of sexual etiquette. When should you invite a person to spend the night with you? Where does your relationship roll into that? how do you please your partner? How do you make sure you please yourself? We try not to go into a lot of techniques, but they have some very factual questions, and we refer them if we think that those questions are beyond what our students can offer. And of course, that our language continues to be LGBTQ inclusive, so that we're speaking to everyone who might decide they want to be sexually active. However, we do not encourage sexual activity. For those students who are not ready and not interested, we want them to know that's just as normal a decision to make as one that might be to become active. On the research side, we just finished about 6 years of studying serodiscordant, HIV serodiscordant African American couples who have been identified by the CDC as at risk for HIV transmission. However, the findings will demonstrate that the resources are not being directed to high-risk populations within particular ethnic groups. So this was an evidence-based intervention, evidence-based by the CDC for couples. And we do have a women-centered approach so that when we talk about STIs, we're also talking about HIV and reproductive health as well. We're not excluding these issues because HIV does not usually include it. We're actually encouraging, and I encourage today that all clinics include STIs, HIV, and reproductive health. It makes sense if you're talking about the body and transmission that you talk about more than just one area. I think other speakers may have discussed that. And it's particularly important to talk about sexual relationships and negotiations with people regardless of marital status. Some of the factors that we saw as huge barriers, and we're writing this information up at this time to present at the American Public Health Association in November, are poverty and deep poverty. We're beginning to look at the effects of fallout of not being able to participate fully, of not being interested in participating at all, becoming incarcerated, or becoming ill during the intervention. But for those individuals who were most poor, and that's what we call individuals living in deep poverty, they're 400% percentage points below the poverty level. So these are individuals who are in a relationship but they have absolutely no resources. And this is really where the virus exists, but there are very few resources. No health care, no transportation, no food, no housing. These are homeless couples. And they are extremely vulnerable. So we are in this article pointing out these issues that don't really come to, I think, the attention of health professionals because they are so far below what we usually hear about in HIV. And those are individuals who may be adhering to PrEP, but these are individuals who are not eating. And they're at a very different point in their lives. And we have to address their overall needs, not just give them information about disease transmission. I think someone else also mentioned to you, and I would like to stress the importance of looking at mental health, because mental health and STIs and HIV really are not addressed well at all. And I think that's a huge oversight. When we talk about people who are adhering to medications and we don't know what their mental health status is, nor if they become depressed or they have histories of trauma and adversity, all of these things are huge barriers to participation in interventions, and yet they're very poorly discussed. So I'd like to recommend that overall, just as in our studies at our Center for Culture, Trauma, and Mental Health Disparities, and Mental Health and Histories of Trauma and Adversity be included. We have the questions to ask. If you have interest in them, we'd love to share them. We've also found that there are many barriers to HIV and STI testing, but we're going to focus on STI testing. Some of the services cost money. They are not free to different individuals, depending on where or which clinics they utilize. The length of wait times varies from clinic to clinic. There's really no standardization across clinics. Some of the clinics are closed for the majority of the week. Some are open. Some have tiny windows for walk-in testing, or they're only available Monday and Friday during the day when most people work. And then there's limited access as well. So all of these things have a tremendous impact on what we were told when we started studying couples some 6 years ago in Los Angeles County. These were all free services, but in fact, they are not free. They are very infrequently used, and it's a mystery as to why clinics keep changing what they serve, who they serve, and how often you can get retested, which is a huge issue in California. In the last decade, we've seen the cuts in STD prevention campaigns. These are also, and I think this has been said before, testing that should be included in HIV clinics, and yet many times they're located across town in Los Angeles County. And for us, that's a huge consequence because we have such a huge county. Some people who have no transportation simply can't get to the testing when they need it. So there are limitations on what people who are very poor and very marginalized and yet very vulnerable can benefit from when it comes to testing at low cost or no cost. But we know that the services are needed in communities where African Americans and other marginalized groups live. But we also know that those services are limited and they have different qualities. So I would strongly recommend that HIV clinics and STD clinics be looked at in terms of standardization of the quality of the care, of the training of the health professionals so that they know how to talk to groups, different groups who have different lifestyles and backgrounds, and some of whom have not been treated very well in the healthcare system. And also screening frequency is different from men to women. This is particularly concerning because women are very vulnerable to STIs, and yet testing is hard to come by, particularly depending on what age you are. You can get a test, one test. Everyone can get one test. But then if you can get that test repeated so that you know that the treatment, if you choose to have the treatment, has been effective and you're not going to transmit STIs to someone else, it is not all available for women. And usually it's very confusing as to who is eligible to get retested or not. However, it's much clearer for men to get tested once and then retested, and particularly for men who have sex with men. We understand that men who have sex with men is the largest group that are vulnerable for transmission. However, women, and particularly African American women, have been number one of those women affected for the last 40 years. And there's literally very little that the CDC or the government will fund that can be standardized across large areas in rural and urban areas for women, and African American women in particular. So this is of much concern that we are leaving populations at continued risk by trying to offer the same models that we offer to men who have sex with men. They're not effective. Women are not being treated, and they're being overlooked. These are examples of the prevalence of gonorrhea and chlamydia. I think you've already spoken about that, but they are very high risk, and they're really not being addressed in men and women. So some of the questions that arise in our research is who qualifies for STI testing. It varies by who you talk to. If you're speaking to a health professional in South Central Los Angeles, where the rates are extremely high, versus if you go into West Los Angeles, where there are fewer people of color, the qualifications for STI testing can vary. It seems like the training and retraining for physicians and health providers needs to be standardized, and everyone is offered the same thing, not just based on the color of your skin or where you live. So some of the questions that we know lead to risk factors are having a STI in the past and having more than one partner, and in the last 6 months having more than one partner, and having certain engaged in certain kinds of sexual behavior. All these are risk factors. But one of the things that we do not ask a lot about is whether these experiences have come as a result of sexual abuse or rape, which makes a huge difference in how this individual who might come for testing is treated or should be treated in the healthcare system. So we need to be more sensitive to the fact that we're not just asking about transmission issues. We're asking about the source of transmission and how that happens. These are all important pieces of information that need to be conveyed during training and retraining and relicensing. We just want to point out one more issue, and it may have been discussed before, and that has to do with the price of the only coverage over large areas of the skin, particularly where the genitalia are located, is almost 5 times more expensive than a regular male condom. The female condom covers more area of the body to protect from skin-to-skin transmission, and yet is more expensive and it has to be prescribed. These are issues that make it more difficult for women to protect themselves. It makes it more difficult for anyone to even purchase a female condom. $5 per female condom is extremely high. We should be outraged at the fact that if we're talking about STI prevention, we're not facilitating conversations with companies that make female condoms to lower those prices so they're more affordable to those people who wish to protect themselves. And finally, I'd like to address some of the questions that you asked of me to address. And these are the ones that I was really thrilled about. So I want to spend a little bit of time on them. Number one is what factors around sexual health must be attended to in order for interventions to be successful. First of all, I just want to say, and I really do thank you for allowing me to have this time to talk, but I think that the Centers for Disease Control and our society has been really very neglectful when it comes to understanding how we have the amount of STIs that we do in this country. That during slavery, this is the 400th year that slaves were brought to America in 1619, and yet we do not acknowledge that STIs have been a part of the consequences of slavery for some groups. And that is because Black women were raped daily for hundreds of years, not only during slavery, but also through the Jim Crow periods of time, particularly in the South, and then through lack of health care access ever since. Those individuals who don't have health care usually tend to be people of color who are marginalized, who speak different languages as their first language, and who've never had the opportunity to have STI treatment and prevention. You know as well as I do, this information is not offered in the schools. How that can continue is just a mystery to me. We have so much to do when it comes to pointing out that one of the most aggressive and egregious parts of slavery was the fact of sexual exploitation that has led to women not having an opportunity to understand how to protect themselves from disease transmission. I have done studies where we have taught women how to not use douching as a way of cleaning themselves. However, for women who were raped daily, it was not a rape kit. It was using vinegar and water as a way of trying to prevent unintended pregnancy or disease transmission. And these habits are hard to break. So for older women, and I was asked about different age groups, some older women will not stop douching. It's just something that's a part of their history. Their mothers have taught them. You see those red rubber bags on the back of bathroom doors as a sign that this is a woman who was about the business of trying to protect herself. And some of the prevention programs really lambast and slam women for douching without acknowledging that these were women who were very proactive. They believed in self-protection. It may not have been effective nor healthy for them, but what was it that they were to do? When health care was denied them, when they are treated differently in the healthcare system, when they're not offered the same kind of information, and when the methods of protection are too expensive, what is a person to do? So we need to start with prevention that acknowledges the history of the neglect and the health disparities that still exist today when it comes to STI treatment and prevention. We have a lot of work to do. People wonder why individuals won't come into the health system, and it's because they have significant medical mistrust about healthcare providers or government issues, programs, devices, or interventions. That, again, may end up being the same kind of experimentation that was done when it came to sexually transmitted infections, condom use, Norplant, and I could go on and on and on about a number of other devices that have all been experimented using African American women or women of color as the main target population. The last factor I'm trying to move to has to do with diversity in women and what they need. We need history. We need education and history. Everyone needs to understand what I have shared with you today, and that's just how lethal it is for us to ignore how women have STI infections without ever asking them. But what means are individuals trying to protect themselves, and what kind of experiences do they encounter today, not 400 years ago, that they may not be able to control, or that they can control, but it's the only means by which they can be able to support their families and feed their children. We are a very naive society and very, I think, prudish when it comes to wanting to be aggressive about education of our bodies. And yet we allowed and have allowed the discussion of slavery and its real impact on sexual health not to be discussed. Recently, some of the plantations in the South have been opened up with a completely different historical viewpoint in an effort to try to teach Americans what really happens. What happens when you go to Thomas Jefferson's plantation? When you see where Sally Hemings and her children live? What does that have to do with the economics and the politics of American society? And some of the tourists are complaining that they don't want to hear about slavery. They just want to hear about, how the house was designed, or, what kind of plants and products came out of the field. We have resistance to these issues, and so that our government, us as professionals, need to take this on to let people know that we can no longer live with our heads in the sand, that we need to be aggressive, proactive, and informative about sexual health in this society. It should not be up to a state to decide if women want to be ignorant and they can't even get services that are legally theirs to have, because we won't speak up as professionals, as college and research educators, that these are issues that we just simply study, and we find that African American women or women of color are at risk for this or that. But we never look at the etiology and the historical damage that's been done with regard to abuse, violence, the use of violence and terror and torture. That's had an indelible impact on the sexual health of women in this society, particularly vulnerable women. In our interventions, just to take on number 4, we have 3 interventions that we call women-centered, even though men are many times participating. But at least when we talk about the body, we talk about a woman's entire body, not just HIV. And I've been funded with HIV funds and programs most of my career. I got my first grant, which was a K Award, and an R01 in 1980. So I've got history myself. I am historical. If you want to study history, study me, in terms of how this whole society has come to these issues. And we can no longer avoid them. But I do have Healing Our Women. That's also an intervention for women with sexual violence histories, and we are currently adapting that in the South African context. The Bond program, which is for serodiscordant couples, which has been adapted for the South African context, and one currently that we are just putting into the field, Healing Our Hearts, Minds, and Bodies. And that intervention reduces histories of trauma and increases awareness and strategies to avoid cardiovascular health diseases. So we are aggressively addressing these problems for health disparities, for individuals who've been marginalized and overlooked. We teach history to every single person who comes into our program. We make them advocates. They are righteously indignated from the time they finish our program, because they know they have a right to information, a right to protect themselves. And it's our society that's the problem. They're the solution because they want to do better. So I want to thank you so much for listening to me this morning, and I'd love for you to ask me questions.
All right. Thank you very much, Dr. Wyatt. We appreciate your taking the call early on the West Coast.